I'm very happy to discuss with Dr. Majid Al-Ahmadi and our esteemed colleagues at the Saudi Myeloma Working Group a recent article mainly focusing on maintenance therapy in multiple myeloma. For our junior colleagues, I'm just going to discuss very, very briefly about some concepts related to maintenance therapy. As we all know, multiple myeloma, unfortunately, is not a curable disease. And it's been known that usually the first remission is the longest remission. And that's why there was a focus on providing a type of treatment, whether it's consolidation or maintenance, that will help in prolonging the remission period without the burden of side effects or toxicity. And thus, there was a lot of discussion early on in the development of the treatment protocols that we know now, mainly focusing on what's the best agent that we can use without a lot of toxicity. Earlier on, obviously, dexamethasone, melphalan was the earlier treatments for myeloma. Obviously, melphalan is really not a good option for maintenance because it's quite toxic and it can cause a lot of long-term consequences that it's not usually beneficial. Interferon was initially early on also trialed, again with a lot of toxicities, and this was not continued. There was a lot of talk about the use of IMiDs, and the first one that was initially trialed was thalidomide. It showed quite excellent results early on in the induction and initiation phase of treatment, but it was found to be, again, toxic. Mainly neurotoxicity was quite heavy for patients, and the rate of discontinuation was actually not small. This is where lenalidomide, which is what we usually use nowadays, was introduced. And there's been several studies, Dr. Majid will go through some of them, that actually showed that adding lenalidomide as part of the maintenance treatment improves the remission period or progression-free survival and prolongs the patient's overall survival as well. There's been a group of patients with high-risk cytogenetics. Several studies looked at adding other treatments to try to prolong their remission period. And that's where the proteasome inhibitors were initially studied. And there were some studies looking at specifically bortezomib, and it did show that it actually improved the progression-free survival in a small subset of patients with high-risk cytogenetics. Going through time, now we're looking at other agents, and one of the obviously novel agents that have been showed excellent results in the induction and early on phases was anti-CD38 antibodies, specifically daratumumab and, for example, isatuximab as well. Daratumumab, Dr. Majid will also go through some studies that initially looked at whether there's any benefit of adding it as a maintenance cornerstone. However, we didn't really have a lot of randomized controlled trials looking at this question per se. So the current practice this is mainly for our junior colleagues, following transplantation, maintenance therapy is recommended for patients who are fit to receive it and have standard risk cytogenetics or standard risk disease. Adding bortezomib does benefit patients with high risk cytogenetics, and it's now recommended to be used as well. The role of anti-CD38 antibodies like daratumumab is not yet clear, despite having some previous evidence to some against, some supports. And this is where our study today that we'll be discussing comes in place. So this is a phase 3 randomized clinical study looking at the role of addition of daratumumab with lenalidomide as a maintenance after transplantation. This was just recently published around a month ago, and I think it will add some discussion points that we will go through today. With that, it's my pleasure to introduce Dr. Majid Al-Ahmadi. He's our consultant hematologist that will be talking about this study today, and we're leading the discussion today. He's the assistant professor of internal medicine and hematology at King Saud bin Abdulaziz University of Health Sciences. He's the program director of the fellowship training programs, specifically lymphoma and plasma cell disorders at Princess Noor Oncology Center. Dr. Majid, the floor is yours.
Thank you, Dr. Hatem, for the nice introduction. And I would like to thank the Saudi Myeloma Working Group for inviting me to speak this night. And I want to thank all of the attendees who are coming to join us today after long working hours. So why we are here? Why we are talking about myeloma? I think for all of the hematologists, myeloma is an important disease to deal with. Why is that? First of all, despite all of the improvement in the care of the myeloma patients, myeloma is still an incurable disease. And now all of the changes in the treatment paradigm is focusing on improving outcomes and prolonging the progression-free survival and overall survival. And for anyone who deals with myeloma patients would know that myeloma is not an easy disease to deal with. Why is that? Because most of the patients with myeloma are elderly, and they are coming to us with their medical background, with their comorbidities, multiple medications. And also, myeloma by itself, comes with its own complications. Bone disease resulting in severe bone pain, cytopenias, renal diseases. And also, one of the challenges in the field of myeloma that unfortunately, until now, we don't have a clearly defined risk adaptive therapy, not like other diseases. So, and we all know now in hematology, we cannot apply the rule of one size fits all. So we have to, justify our treatment based on the disease burden and the risk status of the patients. More importantly, and either we like it or not, the care of myeloma patients produces a big challenge and pressure on the medical system in terms of the cost and the financial impacts. And unfortunately, some important treatment options are not widely available, making the treatment of myeloma patients a bit challenging. Now, what's the roadmap for any patients newly diagnosed who's transplant eligible? So we should all agree about induction. So every patient should receive induction. And then transplant. There are some questions now about going for a second transplant, about going to consolidation, but maintenance is a must. So now, if we want to think about what's needed and must for a care of any newly diagnosed myeloma patients, induction, until now, transplant, and maintenance therapy. So, and the treatment, of myeloma has improved dramatically over the last 10 to 15 years. So I remember during the years of my training, VCD or CyberD was the standard of care. But now this is part of the history. Since the IFM 2009 came and VRD became the standard of care in terms of induction. So in this trial, I think we're all familiar with, patients received VRD induction and the patients were randomized to go for transplant or no transplant. Then everyone went for len maintenance. And this trial showed that VRD is an excellent option in terms of induction, and also transplant still the standard of care with a median PFS of around 4 years for VRD, transplant, and maintenance. Can we do any better? So the answer is yes. So the Griffin trial looked at the backbone of VRD and adding daratumumab to this. So just to remind you, Griffin trial was a phase 2 trial. So patients were randomized to receive DARA VRD versus the standard of care, which is VRD. All patients would receive 4 cycles of induction, then transplant, then consolidation of 2 cycles of the same induction that they have received. And then everyone would go for maintenance based on which arm they are randomized to. So the patient who received DARA VRD would go to receive DARA LEN maintenance. For the patient who received VRD would go for LEN maintenance. So I think you are all agree with me here now. There is no randomization for the maintenance. So we cannot know if DARA LEN would be better than LEN because, there is no randomizing happen here. So this trial showed that the addition of daratumumab to VRD has deepened the response. An important finding that you can see it here clearly that maintenance is not, although we call it maintenance, but in fact, it's not maintenance. It's actually part of the treatment because it deepened the response of the patients. So now looking at the patient response at the end of transplant, you can see here that patients who achieved CR were only 27% in the DARA VRD arm. But after 1 year of Dara-Len maintenance, that response has increased to 80%. So we are talking about almost 3 times. So meaning that you are deepening the response with maintenance. You are not only maintaining it. And the same thing was also noted clearly with the LEN. So whatever maintenance you are giving, you should know in your heart that it's not just maintaining, you are deep in the response. And the same thing for the MRD negativity. So you can see here at the end of the transplant, only 11% achieved MRD negativity, where it was 36% after 2 years of maintenance with DARA VRD. The PERSUAS trial, we're also looking at the same thing, but the difference here now we are talking about a phase 3 clinical trial. So the question was, which one is better, the standard of care, the VRD versus DARA VRD as an induction? The same thing as in the Griffin. So everyone would align with receiving consolidation and maintenance based on which arm of induction the patient was randomized to. So for the patient who were randomized to receive VRD, would go along to receive VRD consolidation followed by R maintenance. For the patient who received DARA VRD as an induction, would go for transplant and then will receive 2 cycles of DARA VRD and then to receive 2 years of DARA LEN maintenance. After that, an MRD assessment will be done. So if the patient is MRD negative, the DARA will stop and the patient will continue on LEN only until disease progression. But if the patient is MRD positive at that juncture, will continue to receive both the DARA-LEN and the disease progression. So the trial showed what was trying to show. So the MRD negativity, as you can see here, was significantly better with DARA VRD. So why I'm talking about MRD? Now, one of the things that I want you to note in myeloma that it's a slowly growing cancer. So to get a PFS results or overall survival, it takes long time now, especially with this very excellent treatment like DARA VRD. So MRD negativity at 12 months is an excellent surrogate marker for PFS, and that was shown by multiple trials. So achieving MRD negativity and sustaining this MRD negativity for 12 months associated with a better PFS, regardless what kind of induction you have received. So basically, now this is kind of a new, a new important milestone in the care of myeloma patients, achieving MRD negativity of 10 to the power of -5, because it is associated with better outcomes. So, and that was shown here. So the sustained MRD, you can see here, it was 64 versus 29%. Now, focusing more on maintenance, so I think the standard of care in Saudi Arabia and in many other countries still the LEN maintenance, and that's coming from the IFM 2005 trial, which actually was a standard, was actually a practice changing, where it showed that LEN maintenance associated with improvement of PFS, significant improvement of PFS, as you can see here, with a hazard ratio of 50%. But the trial did not show survival benefit, which is different from the other trial, which was published almost in the same year, in the same month, in the same journal from USA, from the McCarthy and his colleagues, which showed the same findings, that LEN maintenance resulted in PFS improvement, but also in the same time, there was a survival advantage in this clinical trial. The UK group looked at the myeloma 11 trial, the same question, transplant versus, LEN maintenance versus no LEN maintenance. And the LEN maintenance resulted in improvement in PFS in almost all the group that they were looking at, transplant eligible, transplant ineligible, or high risk patients. So from that point, LEN maintenance becoming the standard of care. And I mentioned to you earlier that the newer trial are looking at DARA-LEN, although no one did a randomization between DARA-LEN versus LEN for whatever induction that the patient received. So the Cassiopeia, on the other side, they tried to answer this question, but in a different way. So the Cassiopeia has two parts. The part one, where they basically looking at addition of daratumumab to a backbone of VTT as an induction. So that's the standard of care in France and in some other countries in Europe, VDD. So patient would receive either DARA VDT or VDT 4 cycles, then transplant, then 2 cycles of consolidation. And then they looked at the outcomes, and in this part of the trial, DARA VDD resulted in significant improvement in PFS and overall response rate and MRD negativity. The second part of this trial, which is the Cassiopeia 2, so regardless what an induction the patient received, would go for a second randomization. So the patient who achieved the PR or better will go for a second randomization to receive either DARA maintenance versus nothing. So, and I think you immediately pick up some caveat on this trial that, we all know that doing nothing is not the best thing to be done for these patients. Maintenance is definitely better, but there was no such an arm on this trial. So either DARA maintenance versus no maintenance. So in this trial, it showed that receiving DARA VDD, showed that the maintenance with daratumumab resulted in improvement of the patient outcomes in terms of PFS and sustaining MRD. But an important point that was reported in this trial, that in patients who were exposed to DARA as part of the induction, that significant improvement with DARA maintenance was not clearly noted. And we can see here the worst patient outcomes for the patient who received VDD. So no DARA pre as an induction and no DARA as maintenance. They did poorly. But anyone who received DARA in their journey of their therapy were comparable. So this trial that I'm going to talk about today, the OREGA trial, which was presented in the International Myeloma Society meeting in Rio de Janeiro in September this year, and was published just a month ago, as Dr. Hatem said, in the Blood Journal. So basically, we're trying to answer kind of the question that we are talking about: what the best modality of maintenance for patients who are newly diagnosed myeloma transplant eligible. So basically, this is a phase 3 trial evaluating the addition of daratumumab to LEN maintenance in transplant eligible patients who are anti-CD38 naive. So keep that in your mind, that patients enrolled in this trial did not receive any DARA as part of their induction. Patient must be in VGPR or better, but in the same time MRD positive. So this is the protocol they used. So the eligibility, patients were from age of 18 to 79. As I mentioned to you, they are newly diagnosed myeloma. They received at least 4 cycles of induction. The induction must not contain a monoclonal antibody anti-CD38. So all of them are anti-CD38 monoclonal antibody naive. And all of the patients were enrolled. They underwent autologous stem cell transplant within 12 months of starting the induction, and all the randomization happened within 6 months from the time of the transplant. So back again, these are monoclonal antibody naive patients. All of them, they achieved a VGPR or better, so a PR will not be eligible for these patients, for this trial. And all of them, they should be MRD positive by next generation flow at a level of detection of 10 to the power of minus 5 post-transplant. So they randomize these patients based on the cytogenetic risk, to either standard risk or high risk. And I want you to know their definition for high risk was 17p deletion, translocation 414, translocation 1416. So in their initial protocol, some known bad prognostic markers like 1Q amplification or gain, 1P deletion were not included in their definition for high-risk patients. So patients were randomized to receive either maintenance of DARA LEN or LEN only. So the patient would receive up to 3 years of that maintenance. The primary endpoint we're looking at was the conversion of MRD to MRD negative, so conversion from MRD positive to MRD negative after 12 months of this maintenance. They were looking at other secondary endpoints, PFS, overall response rate, sustained MRD negativity, and they did, of course, the safety analysis. So in their initial protocol, so basically to detect an MRD difference that will impact PFS, that difference must be 20% or more. And to achieve that, the sample size must be at least 240. So just be careful with that, because that's an important when we are trying to look into this trial. So that's the plan, to have at least 240 to give you a power of detection of 20% improvement in the MRD negativity. So that's the plan. They were planning to randomize 214 patients. They were not able to reach that number. They were able to randomize 200 patients. And that was attributed to the era of that clinical trial. So it was done during the COVID era. So it was difficult to recruit patients during that time. And also, as you have seen with me, that one of the exclusion criteria is receiving anti-CD38 monoclonal antibody prior to randomization. And at that time, the Griffin and the Perseus trial were going on. And as you saw, as part of the induction for that clinical trial is monoclonal antibody. So many patients would receive monoclonal antibody as part of the induction, so they will not be eligible for this trial. So looking at the baseline characteristic of this trial, that this trial has enrolled, elderly patients. You can see 15 and 18% of the patients in each arm, they were older or equal to 70. The trial was done in Caucasian countries, so you can see that most of the patients enrolled were white, so different from our population, different from our genetics. All the patients would have an ECOG of 2 or less. About quarter of the patients were ISS stage 3. In terms of the higher cytogenetics, and you can see here the cytogenetic diagnosis and they're revised. So in the revised, they included patients with 1Q amplification. So you can see here based on the cytogenetics diagnosis, the group of Dara-Len had more 17p in comparison to the Len group. But if we look at the revised definition, the both group had almost similar high-risk patients. You can see here 34% versus 33%, so quite comparable. And in terms of the median number of induction cycle were comparable, 5 to 5. And based on what they mentioned in the publication, almost all the patients were on bortezomib based induction. So I'm assuming VRD. And most of the patients were included were VGPR, as you can see here, 71 versus 70. So in terms of the disposition, so at the median follow-up of 32.3 months, the median duration of the study treatment was 30 months for the Dara-Len versus 20 months for the Len group. And so in terms of the patient who completed the study treatment, and I'm talking about the 3 years maintenance, as we have showed you in the protocol, 33% versus 20% in the Len arm. So if we are talking about the discontinuation, so the discontinuation of the discontinuation of all the study treatment happened in 28% of the Dara-Len versus about 50% of the Len group. Why discontinuation happened? The main reason for discontinuation was progressive disease. So in terms of the patient who discontinued Len, it was related to discontinuation in 23% of the patients on the Len arm versus 11% of the Dara arm. So meaning that there was more discontinuation related to progressive disease really in the Len arm. Regarding adverse event, it wasn't a huge major issue here. So it was comparable between the Dara Len versus the Len group. And when we look at discontinuation in the daratumumab related to adverse event, it was noted in 6% of the patients who were treated with Dara maintenance. So the study actually met its primary endpoint. So you can see here there was statistically significant difference in terms of MRD negativity at 12 months of treatment. So 50% of the patients on the DARA arm achieved an MRD negativity at 12 months in comparison to 18.8 months in the LIN arm. Putting in your mind that the MRD data was not available for all the patients. Why is that? Because by the time that they they did their primary analysis, some of the patients were still did not receive the 12 months of maintenance. So, but the available data were recorded in 88 patients in the Daralin arm versus 82 patients in the arm. Despite that, you can see here the difference is about the same. So we're still talking about 30% or more difference in MRD negativity. And I've told you what was needed to consider this a positive trial is 20% difference, where they were here more than 30% difference. What about the patient who achieved CR or better with MRD negativity? The same thing. The difference was about 30%, 44 versus 14.9. So these positive outcomes were noted in all the subgroup of this trial, namely even in the patient with high-risk cytogenetics. So meaning that having high-risk cytogenetics did not resulted in a significantly worse outcomes in this particular trial. So what I'm trying to say here, maybe Daralin considered as a better option for high-risk patients. That's I cannot reach to a final conclusion based on the small sample size, but there is a hint of this finding in this trial. So what about sustained MRD negativity? What does that? So their definition for sustained MRD negativity in this trial is maintaining the MRD negativity for more than 6 months. So as we said, that the initial MRD analysis was done at 12 months of treatment. And then how many of these patients would maintain that MRD negativity for 6 months? And it was also of more than 20%. So 35.4 versus 13.9. So more maintained MRD negativity. What about a deeper MRD at a level of detection of 10 to the power of -6? So the same thing, we are talking about almost 20% difference, so 23 versus 5% in the LIN arm. What about the overall response rate? So the addition of DARA to maintenance of lenalidomide associated with a better overall response. As we can see here, the CR or better was 75 versus 61 in the LIN arm. So basically, addition of DARA resulted in deeper responses with deeper MRD negativity. That was translated in an improvement in the PFS. So PFS of 82 versus 66% with a significant p-value, but definitely a longer follow-up required for such finding. An important finding you can see here, which actually reflects what I have said before, that regardless what treatment you're going to receive, you are going to give for the patient, if the patient achieve MRD negativity, they do better. So here you can see even the patient who received LEN maintenance, but they achieved an MRD negativity, they did well. So meaning that anything you give result in MRD negativity, that's great. In terms of the safety, so there was no significant safety alarm in this trial, but as we know from clinical practice that addition of daratumumab would result in a slightly worse in the cytopenias and also the risk of infection. So as I mentioned to you, this trial was done during the COVID era. So there was grade 3 and 4 histories of pneumonia, as you can see here, and most of them were related to COVID-19, but there was no significant difference in terms of infections or cytopenias between the two arms. In terms of the infusion reaction, it was mainly grade 1 or 2, and mainly it was happening in the first cycle of daratumumab. So, the conclusion of the author from this trial that addition of daratumumab to lenalidomide maintenance resulted in doubling or even more than double of the MRD negativity in that group of patients, and also resulted in improvement of the PFS up to the 83%, with a 47% risk, reduction in the risk of disease progression or death. No new safety concerns. So now, if we want to look at the details of this trial, so what was the research question? So the question was to compare the efficacy of dara-len as maintenance therapy versus len in newly diagnosed myeloma patients post-transplant. Is that a relevant question? Definitely yes. But we need to put in our mind that all patients received DARA as part of all the patients did not receive DARA as part of their induction. So if we are giving DARA VRD as an induction to our patients, this trial maybe did not, answer this question clearly to us. And I know now many centers in Saudi Arabia and all over the world moving toward quadruplet therapy as recommended by the NCCN guidelines and by ISMO guidelines. Still did not inherit that, but I think in the more recent update will be coming from them. I think the quadruplet will be as a standard of care in their recommendations. And why I'm saying they did not answer that question for us, because if I gave a patient DARA VRD and I took this patient for transplant, am I doing too much of benefit by giving DARA-LEN? Maybe yes, but maybe the fact that the patient did not go into a very deep response, that he has just a resistant clone, that giving DARA maintenance might not be enough, maybe doing something else for that group of patients. Unfortunately, that specific question was not clearly answered in this trial. So all the patients were DARA naive. In terms of randomization, so they did a good job in terms of randomization. So the patients were randomized in 1-to-1 ratio. We have seen that when they were going into the initial cytogenetic risk, patients who received DARA-LEN had more patients with 17p. In fact, me seeing that made me more comfortable with the results. I would say that the opposite thing, if the patient who received LEN had more 17p. So that would be a huge confounding factor. But the fact that patients were receiving DARA-LEN had more 17p, that's, I think, something good for this trial. The sample size, definitely, it's a small sample size. We are talking about 200 patients in general. It was less than what was planned, and as I mentioned to you, because of difficulties in recruitment. One of the issues with this trial that it was an open label. So as you know, open label trial might result into some potential bias, especially with reporting side effects. people might overcall side effects just because they know that they have more treatment. So that bias might happen. The follow-up was the 32.3 months. Some patients did not reach even 24 months of follow-up. So meaning that the follow-up in this trial is not long enough, but at least it's good enough to give us the initial analysis as we have seen here. There was actually a significant dropout of this trial, slightly higher in the R group, 14.6% versus 8.2%. So the primary endpoint, which is the conversion rate, at 12 months was significantly different in favoring of DR, 50.5% versus 18.8%. With a strong odds ratio and a significant p-value. Secondary endpoint, progression-free survival was improved with DARA-LEN, as we have seen here, with a significant hazard ratio of 0.53. Higher rate of deep responses also was noted in the DARA-LEN. The incidence of grade 3 or 4 adverse event in terms of safety was not significantly higher with the DARA-LEN in comparison to LEN, meaning that the use of DARA-LEN as maintenance was not associated with a significant safety concern. So applicability. So the population, we have agreed that, you know, if this trial might not represent the population that will be treated in 2025 or 2026, because I think most of the patient in the next 1 to 2 years would receive quadruplet versus triplet. So a more trial looking at that specific question with for patients who receive DARA-LEN with addition of DARA to the maintenance superior to LEN alone, putting all in your mind that addition of DARA would associate with the significant cost and burden to the health system and all of that. So that's actually basically summarize the limitation of this trial. The open label, the duration of the follow-up was relatively short, and as I mentioned to you, the group of patients were treated were monoclonal antibody naive. So my take-home message to you that DARA-LEN might be a new standard of care as maintenance therapy for newly diagnosed multiple myeloma transplant eligible, but longer follow-up is needed for this trial, and also more trial is needed to answer the same question, but with the use of DARA as part of the induction. For here, I want to stop, and I want to thank you all for your attendance and for listening to me.
Thank you very much, Dr. Majid, for this very excellent, detailed, and well-structured appraisal of this article. That I really do think that it needed such close eyes to review it. I agree with you 100%. My main issue with the study and the results is it was the design itself was tailored towards possibly finding a benefit with adding daratumumab. You're selecting a group of patients who were not exposed to daratumumab before.
Exactly.
You know that they're MRD positive, and you're adding more treatment to them.
Yeah.
You would suspect that they will probably find benefit in that.
Yeah.
The other main issue that I find is up to even this point, even in the United States, I don't think MRD testing is standard of care in the clinical setting yet. If you want to select patients based on the trial, you should include patients who are MRD positive. I would probably not, which makes things difficult to whether to add that or not to those patients. This is especially here with the cost associated with daratumumab, having a 3-year maintenance of dara that you're not quite sure whether it's going to add much other than treating patients that you know that probably eventually they would need treatment, it makes things a bit more vague. I think it raises more questions rather than answers, but it confirms that daratumumab helps in deepening the response of patients. Dr. Ghazi, Dr. Ayman, the group, if you have any comments, I would welcome it now.
Dr. Ayman.
Yes, thank you, Dr. Ghazi. Well, of course, I agree. Thank you, Dr. Majid, for this elaborative presentation of the trial and the critical appraisal. I agree with everyone that there are really too many questions to be answered that were not yet there. I mean, certain groups definitely have different responses based on what they have been treated with and the risk status of their disease. We have learned, I mean, from other even diseases that low-grade lymphoproliferative disorders benefit from maintenance treatment. And the best maintenance treatment that was studied in myeloma is lenalidomide. And nobody has any doubt that lenalidomide is a standard of care for these patients. Now, a small study showed benefit of bortezomib. From the 40 trial showed benefit of carfilzomib plus lenalidomide. Now, I mean, there is more than one study that have shown benefit of adding daratumumab to lenalidomide, either the Griffin or the Perseus, and now the Auriga trial. So, I mean, to cut it short, I mean, definitely there are patients that need to be maintained on something more than lenalidomide alone. In practice, as you know, we do mostly dual maintenance in high-risk patients, adding bortezomib, and that's based in a very small study and a very, a non-randomized evidence that we are convinced probably that these patients need more treatment as maintenance in addition to lenalidomide. Now, with these, results, which patients would I use the addition of lenalidomide to, the addition of daratumumab to lenalidomide? That becomes really difficult, especially this trial was designed in MRD positive patients. And as Dr. Hatem mentioned, MRD testing is not widely available everywhere. I mean, we have tried to do MRD in many of the patients, and we still, upon asking, our hematopathologist is enthusiastic to do the MRD testing by flow, not by NGS. And there are really definitely certain questions, but definitely, especially high-risk patients, whatever more additional treatment you give them, they're going to benefit for sure. Dr. Ghazi.
Thank you, Dr. Ayman. I tend to look at this from a different perspective, to be honest. I think if you see the 2024 update of Cassiopeia, you can note that although the comparison included an observation in maintenance, but even those who received daratumumab in the first part, they benefited from daratumumab in the maintenance phase. So difficult to look at one study from one side. I think I agree with you that we don't. If you're giving somebody now VRD as a backbone induction, giving them lenalidomide with daratumumab definitely deepen their response. And in this short follow-up study of 30 months, we think compared to len alone, it's probably better to give dara. And so, you get an answer to a question that we ask ourselves all the time. If somebody is getting VRD, does addition of daratumumab maintenance improve PFS? So I think the answer is yes. So now, in those quadruplet patients, I think you can answer this question from the combination of the Perseus and the Griffin trial. Those who received quadruplet inductions, you really have to give them maintenance with daratumumab and lenalidomide to achieve this impressive 60 months PFS of that study. So I think these are all complementary studies, difficult to isolate. It probably doesn't answer the question in most people's head of if somebody is MRD negative post-induction, do you give them Len maintenance? Do you give them Len data? Still, so many unanswered questions. But I think the concept of do you deepen the response after maintenance? I mean, after consolidation or induction to improve their PFS? I think it answered this question. Yes, if you deepen the response, they do much better.
True.
You do
But
calcate.
regardless what you're gonna give. So if you achieve that MRD negativity, you're doing well. Yeah.
Yes, but 60% of people don't achieve MRD negativity after transplant. You only get about 40% MRD negative. So in those
I totally hear you. But now, okay, for the Griffin and the Perseus, okay, the quadruplet given, they get to consolidation. But then how about if those patients were received only Len maintenance? Would we get the same outcomes? I don't know. Maybe yes.
So this study,
maybe just they had a deeper MRD because of the very good induction and consolidation that they have received, and just maintenance with Len would have done the same thing. I cannot answer that question.
In this study, when they looked at patients who became MRD negative with Len alone, they did not equally,
Exactly.
but as well.
As good as so.
Regardless whether you gave Dara or Len, as long as you reach MRD negativity, then probably.
But the point of Dr. Ghazi here that the addition of Dara, Len as a part of maintenance, it's the cause of that very deep, sustained MRD negativity. Maybe yes, I agree with. But
well, this study is showing this. Prior to the study, we didn't know that you really have to deepen the response to get a better PFS. There's no data to suggest this. So this study has said, well, if somebody is MRD positive, addition of data, deepen the response and improve their PFS. I would take it at this point. I wouldn't say, well, maybe if data is used in induction, you don't have to do it in the maintenance. And then you go into the Cassiope argument, prior to the recent update.
No, but I'm saying if so now. So Dr. Ghazi, let's put the question on the other side. Now, if you have a patient who has achieved MRD negativity after quadruplet induction transplant, I think this is the patient that we were not sure to. Do we need to give more treatment? Would Len alone be enough? I don't know.
Yeah. We don't know. But okay. If you're giving a quadruplet induction, I would just proceed with your Perseus protocol.
And on the other side, for the patient who are MRD positive after, based on this trial, they received 6 cycles of DARA containing treatment. If they did not achieve MRD negativity after that, with giving more DARA will help to achieve MRD negativity. For me, the answer is not clear, because maybe you have that subclone that resistant to DARA. Giving more DARA will not, change anything other than just increasing risk of infections, putting more financial toxicities, and all of this. I see it from that perspective.
If you allow me to comment about patients who have bad disease in general. I mean, to the contrary of our belief that we need to give more treatment in patients who have bad disease. And you can define bad disease the way you like. Not achieving MRD negativity means that they have a bad disease. Having high-risk features, they have a bad disease. And we always think that we should treat those with whatever modality of additional treatment, and not the patients that they have good biology disease. But all trials has proven that the benefit is remarkable, or even more in patients who have good disease, not the bad disease. Even in this trial, if you show the forest plot, those who benefited more are those who have low-risk disease, not the high-risk disease. So I don't think, patients who have MRD negativity at the end of induction or post-auto transplant will not benefit from the addition of daratumumab. In fact, I believe they will benefit more than the patients who are MRD positive. But I agree with you, this was not included, and we cannot swear that this will happen. But this has been repeatedly happening in all trials that good biology disease benefit more from additional treatment
True.
as compared to bad biology disease.
Very true.
Can I just add a comment, please?
Sure.
Hi, Imran Taylor here. I think it's not only achieving MRD negativity at one point. What is important is sustained MRD negativity. So there's a master trial that looked at MRD negativity at 18-month landmark. They used double consolidation. So there was clearly difference in PFS, the two curves widely diverging. There was another study that looked at MRD negativity among LEN maintenance patients at 12 months, 24 months, 36 months. So that was again clear evidence that those who have sustained MRD negativity did better, both in terms of PFS and overall survival. So I think these drugs can achieve MRD negativity initially, but maintenance will deepen it further. And as you can see in the Auriga trial, there are more conversions to CR. And again, even in the Perseus trial, more MRD negativities in the DR. I think the maintenance DARA does add in deepening the response, as we saw in Griffin and as well as in the Perseus. And again, in the Cassiopeia, daratumumab maintenance arm, even though they didn't get DARA in the induction, they did almost equally well, especially in our setting where we don't have too many access to newer drugs, timely clinical trials. Even if it saves 1 or 2 years, PFS improves. I think that will save a lot of money for our patients because they come from so many thousands of kilometers with their family, loss of work lives, and also the watchers get leave. I think in the end, I think they benefit. Anyway, the SWOG trial, the dramatic trial, and GMMHD7 trial are going to answer this question. DARA or ESA R versus R alone in the coming future.
True. Very true.
Thank you very much. So before we close, I just would love to hear from all of you as a vote. Would anyone now add DARA as part of their maintenance? And if yes, to which patients?
I was expecting that question. Okay.
So what do you think, Dr. Majid?
So in Precision Neuro-Oncology Center, we decided to continue with LEN maintenance. So we are using quadruplet for most of our patients. And until we have a more mature data, we decided to continue with LEN maintenance, no DARA. This is what we are doing right now.
You said yes.
I
have treated quite a few patients with DARA maintenance before even the Auriga and the Griffin. Mainly because these patients, I guess you have such patients in your practice too. I mean, when you believe that the addition of daratumumab to their induction or to whatever therapy they have received has made a big difference, and they have some form of high-risk features, you will be tempted to keep DARA on board as opposed to no DARA. And I have quite a few patients that are on maintenance with daratumumab in addition to lenalidomide. Now, if you ask me, I would probably pick patients with high-risk features, as we have thought of most of the time, that probably these patients will at least, the benefit they get, prolong their progression-free survival as compared to LEN alone. I would probably do that. We're doing dual maintenance now with bortezomib. Will I change bortezomib to daratumumab? Maybe.
Allah Dr. Thank you very much. Dr. Hazi?
Nothing much to add, to be honest. I agree with what the group have said. In those who are receiving quadruplets, we give them maintenance with daratumumab and LEN, and in those who on VRD, like the usual practice, remains in those who had VRD, and they're doing okay. But it's very tempting. Instead of giving protism every 2 weeks, might as well just switch to Dara monthly.
Yeah, but the issue is with patients who have not had DARA before,
Right.
whether adding it in maintenance when we don't really have MRD testing to select those patients. I think that's the question. But if they've had it in induction, it makes it a much easier question. All right, thank you very much, all. So with that, I think we'll conclude our second wave. And thank you very much for everyone who attended. And thank you very much, Dr. Majid, for this excellent talk and being on time as well, Dr. Ghaz, Dr. Ayman, and everyone who's attended. Thank you very much.
Thank you.
Thank you. Assalamu.
Thank you so much.